Well, so thank you so much for the organizers, for Olivia and John, for inviting me. Today, I'm going to be talking about the effects of rising health costs on retirement security. So I'm taking a little bit of a longer view than just COVID. In fact, not looking at the COVID area at all. And this is joint work with Glenn Follett from the Federal Reserve Board of Governors. And so the standard disclaimers about this being our views and not those of the board or any of the members of the staff apply. Okay, so as you, I'm sure all know, healthcare spending has been and is expected to continue to be a rising share of GDP over time. Out-of-pocket healthcare expenses, including premiums. So when we talk about out-of-pocket in this whole presentation, we mean co-payments, deductibles, co-insurance, but also the Medicare premiums or other premiums for Medigap that the elderly pay. So whatever the elderly pay from their income. They're a very large share of the elderly's total spending, about 14% on average for 65 plus versus 9% overall in 2021. For the low-income elderly, that share is much larger. And here, this is as a share of income, about 30% of income in 2016 in the bottom quintile, according to our calculations. So high healthcare costs can be a large burden on elderly households. In the way that we think about burden is in the sense that other consumption is crowded out, right? So how much do you pay for your healthcare? What do you have left over to use for everything else? And so because of that, the burden depends very much on the share of health spending. So like a 10% increase in health costs has much larger effects on this income net of health expenses when the share of health spending is 50% than when it's 5%. So together, the fact that the elderly spend a large share of their income on health and that the health spending has been rising over time, you would expect that the burden of healthcare expenses has been increasingly burdensome for the elderly over time. But in a paper in 2008, Glenn and I found that actually the burden of health spending had been relatively stable from 1987 to 2004. Why was that? That was because every time it looked like healthcare was become less affordable, federal financing actually expanded. So that you see a larger role for federal health, for federal government and health care financing. So in this paper, we asked what's happened since we wrote that last paper to affordability, and then looking forward, what's going to happen. That paper focuses on everybody. This one's going to be focused on the elderly. So you can look at the data that we use from the paper. I don't have time to go through it, but basically we're using the MCBS and the HRS for income in a way that we sort of try to impute income to fix the bad income in the MCBS. So this picture is showing you out of pocket, again, including premiums, spending as a share of income by income quintile. And I want you to get two things from this picture. So the first thing is you go across the bottom, the 1, 2, 3, 4, 5 quintiles, you'll see that health expenses are most burdensome for lowest income elderly. And that's a little surprising. You're like, well, don't they have Medicaid? And doesn't Medicaid pay for everything? And so the answer is Medicaid really does lower the share of health costs paid out of pocket, but only about 45% of the people in the lowest income quintile and 10% in the second one have Medicaid for the full year. So there's a lot of people who only have partial Medicaid or don't have it at all. And therefore, health spending is quite burdensome on average for people in the lowest income. The second thing I want you to see is within each of these quintiles, if you look, you kind of see these things are going down over time. So out-of-pocket spending has been declining share of income, right? Not even a rising share, a declining share. And since 2005, which is kind of we'll concentrate on, one of the main reason is really that total health spending, not just the part paid for by the elderly, but the part paid for by Medicare, everything. Total real health spending deflated by the GDP deflator, not some health deflator, has actually been pretty flat since 2005. So it hasn't increased very much for the elderly, while income has been rising. That gives rise to the decline. And also there has been an increase in public financing, just as before, the most important example being Medicare Part D, which covers prescription drugs, and that lowers the private share of spending. And so those two factors have meant that actually the burden of health spending has not increased over time since at least 2005, well, since 1996 in these. So what accounts for this lack of growth in elderly health spending? Like what's going on? We always think about health spending growing so fast over time. So to a large but uncertain, and we could probably have a debate about it, extent, I think a lot of it has to do with the ACA and other Medicare reimbursement policies. So the ACA really lowered how much providers, particularly health providers and non-physician providers, were paid, and it lowered the annual updates every year. So like instead of being paid the input cost, it said it's input cost minus like 1% basically every year. Physicians have really, in Medicare, have really not increased physician payments sort of on a per service basis very much at all over the past 20 years. So now if we compare Medicare spending, how much did it rise since 2010 relative to what CBO projected before the ACA in 2009? So by 2019, Medicare spending was 20% less than projected in 2009. Now, GDP was also really weak over that period, of course, but still, as a share of GDP, Medicare spending was 14% less than projected. Why does that matter? That matters because lower Medicare spending, lower provider payments, reduces spending on deductibles, copays, and premiums, because those are all tied by formula to Medicare costs. So like the Part B premium is supposed to be 25% of costs. So if expected costs go down because reimbursements go down, that's going to have not only effect on the federal deficit, but also on elderly. And so what we do is we calculate to measure this affordability. We use this concept I talked about before, this income net of health spending, health expenses, which is very similar to the idea behind the supplemental poverty measure, which also subtracts out-of-pocket medical expenses. And so this is what I show in the chart on the right. For the people in the lowest income quintile, the slowdown in Medicare spending relative to what was projected pre-ACA increased income net of health expenses by 16%. That means they had 16% more to spend on things other than healthcare than they would have if Medicare had kind of gone along the trajectory that CBO expected in 2009. For the second quintile, increase was 9%. And MedPAC, which is an agency that looks every year, well, what's happening to access to providers? Like, can Medicare people still see the same doctors? Can they go to the same hospitals? Has said that access has been quite good. And so Medicare beneficiaries still had good access to healthcare providers, were paying less for healthcare, so they were clearly better off. Okay, so now we're going to move to looking to the future. In the paper, we do two sets of simulations. I'm not going to have time to show you both now. I'm just going to show you the first one. So we evaluate spending for a 65-year-old today over time. And we're like, how much does what happens to health spending affect their retirement security over time in the same sense that we're looking at sort of how much do they have left after health spending to spend on other stuff. Okay, we assume that income after 65 increases with inflation. That's a pretty good assumption for people in the bottom 2-3 quintiles who get most of their income from Social Security, SSI, and some pensions, most of which are indexed to inflation. It's not going to be as good of an assumption when people have a lot of asset income, but that's not really a huge problem in the bottom quintiles, which is where affordability is of a concern. One of the things that we do, which is an innovation in this paper, is we consider the effect of health prices on the CPI. Right. So one of the things that fuels excess cost growth, fast growth of health spending, is the fact that at least measured CP prices for medical care grow faster than measured price than sort of the GDP deflator or other elements of the CPI. And so how much does that help the elderly in terms of saying, well, yeah, health prices went up, but so did your income. And so you're not necessarily worse off in terms of what you have left for everything else. So we'll look at that. We allow Medicare growth to diverge from growth of total health expenditures. And the only reason total health expenditures matters is for the CPI effect, right? It's what's in the CPI basket, not Medicare only. So we allow Medicare growth to diverge. We examine 3 excess cost growths, and excess cost growth is basically growth in excess of GDP. So if GDP is 3 and healthcare grows at 4%, then excess cost growth is 1. So we've examined 3, 0, 1, and 2 for both NHE and Medicare. And to put this into context, for 2031 to 2051, CMS, the Center of Medicare and Medicaid Services, assumes excess cost growth averaging 0.5% for Medicare, so between the 0 and 1, and CBO has much larger excess cost growth of 1.15. Okay, so let me show you the results. Now, so health spending rises with age. So even if like nothing was happening to health costs over time, if the real dollars were just exactly the same, you would see an increasing burden of health spending as people got older. We didn't want to focus on that. We were trying to isolate the effect of health costs. So in this example, what I'm going to do is compare this net income, subtracting health expenses from income, for what happens under our health cost assumptions versus one where there's no growth in health spending, in real health spending. Okay. So this is what the table is showing. It's showing this percent change in income available for other stuff by quintile, by age. And so you can see that the effects get much larger regardless of the excess cost growth. This is our 0, 1, and 2, and only 2. This slide has no effect on the CPI. They're much larger for older people for 2 reasons. One, we're sort of starting excess cost growth at 65, so it's sort of accumulating over time. And 2, health spending is a much higher share of income for older people. So any changes in health spending on health costs just have a much larger impact on the sort of money available for other stuff for older people. And so for the lowest income quintiles, even 0% excess cost growth, which is quite low, we would say, oh, that's fantastic, lowers net income by 12%, by 75 to 79, and much larger at older ages. 1% excess cost growth, which is below what CBO is assuming, causes, really major affordability problems even by age 70 to 74. We're talking about 10% if we look in this middle column, and 24% by 75 to 79. So there's a real issue of healthcare costs leading to lower income available for other things. Now, we're not talking about welfare here because we have to talk about the value of the health spending that they're getting, but we are talking about sort of retirement security in terms of being able to afford rent, food, everything else. Now, what about the CPI? Doesn't that help? So in this example, we use a huge increase in the CPI that's much larger than anything that we expect, which is that national health, NHE grows 2% excess cost growth, and it's all prices. And when we do that, you see the CPI adjustment helps, but not a ton of effect. So let's look at 75 to 79. It's minus 12 with 0% Medicare excess cost growth versus minus 9 with the CPI. So it helps a little, but it doesn't really do a lot. Why is that? It's because the health spending share of the CPI basket is just so much lower than the share of health spending and income for the elderly that it just can't do that much, right? So it affects your income, but your health expenditures of your low-income elderly are just so much larger as a share of your consumption that it's not going to really protect you very much. Okay, so policy implications discussion. So first of all, just to repeat, slow growth in Medicare spending helps increase healthcare affordability for seniors, and it helps the federal budget. We're very used to thinking about it helping the federal budget, but thinking about what it does to seniors is really important. Of course, providers were worse off. This is not like a mystery. It's like, in some sense, a tax on providers that is used to increase healthcare affordability. Even with modest excess cost growth, however, affordability will become increasingly difficult over time. So then the question is, well, what can payment policy do to contain health spending? Can we continue to keep it really flat? If we can't, then demand for expanded federal financing of care will rise, just as it has in the past. So that means that these long-term budget challenges that we all know about could actually be larger in some sense than reported, because there's going to be a lot of demand to help lower income elderly pay more of their health expenses over time, because it's going to become increasingly unaffordable as in the past. On the other hand, CBO has a pretty high excess cost growth. So they're greater than 1%, much higher than CMS. So when we're thinking about the CBO long-term budget challenges, in some sense, there's room in the budget relative to current projections for expanded federal financing of healthcare for lower income elderly, if it turns out that healthcare cost growth isn't as high as they think, which I think is certainly not for sure, but is a possibility. So thank you.